Now we're going to hear from Dr. MacKintosh. She is a pediatric pulmonologist and sleep medicine physician at Seattle Children's Hospital and the University of Washington. Her clinical and research interests include care of critically ill children and the use of technology to improve comfort and breathing for kids with chronic illness. She is one of 4 pulmonologists who provide specialty care for children and youth with neuromuscular disorders in the Seattle Children's MDA Care Center. Thank you, Dr. MacKintosh, for being here. I will go ahead and let you present your slides.
Perfect. Thank you all for having me. All right. So thank you all for having me. You're an intimidating crew. You have lots of good questions, so I'm excited to see what we talk about at the end. I have no relevant disclosures. I am going to show some different devices and things that are marketed, but I have no affiliation with any companies, and I will show an assortment of things with no favorites. And I just wanted to shout out some gratitude to Dr. Amanda Striegel, who some of you may have seen at prior meetings. She's sort of the Pacific Northwest neuromuscular pulmonologist. She's been a mentor of mine for the past decade and has been leading me along these past many years. So I am going to run through a couple of things. First, I'll talk about sort of breathing, how it happens, how we do it right, where things can go wrong, and then a few things in specific where, in particular, with the different limb-girdle muscular dystrophies, things can not work as well as we would like them to. Talk about how we monitor these, both with lung function testing and sleep studies, and then talk about the different sort of equipment and devices and medications we have to help with breathing, both when folks are well as when they're sick. So first off, to talk about just breathing and how it happens, and this is not specific to any muscular dystrophies, this is just breathing. The 2 main jobs that we think about for the lungs are 1, to oxygenate, to get oxygen into the body and delivered to the tissues that need it. And then 2 is ventilation, which is getting the carbon dioxide your body makes out of the body. So those are sort of the 2 main jobs. Sounds easy, good air in, bad air out, but there's a lot of complexity that goes into it. And when, as a pulmonologist, we're thinking about breathing, we sort of break things down into different what we call compartments as sort of our mental model. What are the different parts of the body that go into breathing? And then when someone is having trouble breathing, we sort of go through and map out which one of these compartments is not working as well as we would like, and that helps lead us into how can we help treat this. So some of the compartments that are not classically involved with limb-girdle muscle dystrophy are, so the brain, we think about is the drive to breathe normal. That's not typically an issue. Lower airways and the lung tissue themselves, the lung parenchyma, are not classically involved, although there can be, long-term side effects if somebody has asthma or emphysema or has had lots of pneumonias, then we can start to get into that, but it's not really a classic problem with the muscular dystrophies. The space sort of around the lungs, the pleural space between the lungs and the chest, also not really classically involved in muscle dystrophies. The big compartments that we think of in terms of breathing and where things can happen differently with muscular dystrophies is the upper airway, particularly if there are swallowing difficulties or bulbar and throat muscle weakness, that can cause troubles with breathing. If you're inhaling either your saliva or things that you're eating or drinking into the lungs, that can cause troubles. When we go to sleep and we relax, our airways also relax. And if you have sort of loose muscles in your throat can relax more than others. The chest wall and the diaphragm are sort of the big hitters, the things we really think about in terms of breathing differences with muscular dystrophies. So the chest wall is the ribs, the muscles that connect the ribs and help support breathing, the spine, which really provides the structure to the chest and holds the whole thorax open, and then the diaphragm, which is the major muscle for breathing. Those are sort of the 3 main compartments that we think about. When we look at the muscles of breathing, There are some differences. We use different muscles for inhaling and exhaling, and different muscles for breathing at rest and breathing when we're sick or when we're exercising. So there are some sort of classic muscles of when you're inhaling, when you're breathing in. The diaphragm is the major #1 muscle for breathing, but we use the muscles in between the ribs are important for providing that structure and stability of the chest to help keep the lungs nice and open and help support breathing. If someone is exercising or breathing hard, then we also start to use some of the other muscles in the neck and the upper body, and then more muscles in the chest, which can then be more likely to be affected with the limb-girdle muscle dystrophies, which is why some folks may notice that they breathe just fine at rest, but then start to have more trouble if they're exercising. And then when we're exhaling, we don't usually actually think about breathing out. It doesn't take any effort. We do the work to breathe in, and then we relax and air goes out at rest. So when you're just at rest, nothing's happening, we don't actually have to do work to exhale. Usually it's sort of a freebie. If somebody is exercising or breathing hard or trying to do something like cough, then we start to use some muscles to exhale. So some of the other muscles that go in between the ribs and then the abdominal muscles especially are important. So for breathing hard, we do then have to do work to get air in and then more work to get air out. In sleep, breathing is a little bit different also than at rest. So if you are awake and relaxing, you're not thinking about it, but you are using the muscles in your throat and your upper airway to sort of hold things open, hold your airway nice and wide in your throat and behind your tongue. When we go to sleep, we stop thinking about that, or our brain, even our subconscious, really stops doing that. And so as we go to sleep, we relax and our throat essentially collapses a little bit. And so you go from having a nice wide airway when you're awake to a more narrow airway. So you've got a smaller tunnel to breathe air through. So that can sometimes cause, for anybody, more work to breathe when you're asleep. And then in certain stages of sleep, the REM sleep, the dream sleep, the rest of your body actually relaxes. Your muscles lose their tone. And so the diaphragm is no longer depending or no longer getting help from those muscles in the chest to breathe. And so the diaphragm becomes much more important in REM sleep. So if you are someone who depends, if you have diaphragm weakness and you're really depending on chest wall muscles to breathe, then in REM sleep, that's going to be much more difficult to get the good air in and the bad air out. When we are asleep, everything sort of goes into overdrive. Excuse me, not asleep. When we are ill, everything sort of goes into overdrive. So you have to use more muscles to pull air in and push air out through swollen airways, nose with lots of congestion, sore, swollen throat, just lower airways in the lungs that are filled with congestion and mucus, makes it harder to breathe. And then in addition, you need to cough those secretions out. It's really important for the health of the lungs to clear your secretions that you're making. We're all making secretions in our lung all day long, and then our body is constantly clearing it out. If you take a big sigh breath, that helps move things along. Every once in a while we cough, helps get things up and out, becomes more important when we're sick. And so when you're sick, really your breathing muscles, both your inspiratory and your expiratory muscles have to work harder to breathe. One of the most important jobs of breathing during illness is to cough. Cough it seems like a really simple thing, but when you think about it, there are actually multiple steps that we do. So to cough, you first actually have to take a big deep breath in. Then you close your vocal cords, start pushing air out and building up pressure behind your cords, pop them open, and then it creates this sudden flow. And so it helps, the sort of rush of air helps carry mucus and debris up with it. So if any part of that process is interfered with, you can't cough very effectively. So everyone thinks of cough as being you cough out, that's where the work is. But if you think about it, if you exhale and then try to cough, it's going to be a really wimpy cough. You really need that big inhale first to make it effective. So to cough well, you need to have good muscles to breathe in. You need to have control over your vocal cords to close them up and build that pressure behind it. And you need to have good expiratory muscle strength. So it's more complicated. It's something that many of us do without even thinking about, really take for granted, but there's a lot that goes into it. And so we see with different muscle diseases, breathing can be affected in different ways. Especially for something like the LGMD, where it's really almost sort of an umbrella diagnosis with the multiple subtypes. The different types can have different muscles involved, different patterns of muscle involvement, different timings of when and how significantly muscles get involved. And then even within the same type of LGMD, even individuals in the same family with the same genetic difference can have different degrees to which their muscles are affected. So if you have inspiratory muscle weakness, it can be hard to get air in. That can also then make it hard to cough. If you have expiratory muscle weakness, that's going to be more of an issue if you're exercising or when you're sick. If you are someone, an individual who has a weak diaphragm, let's say it goes along with a particular muscle dystrophy, or sort of the classic situation as a pulmonologist where we think about weak diaphragm as somebody with a spinal cord injury. If you have a weak diaphragm, then you really depend on those muscles of your chest to help breathe. You depend on the muscles of the chest to help lift the chest and pull the chest open for breathing. So normally, if someone with normal muscle strength breathes, when you inhale, your chest and your belly all go out together, and then when you exhale, everything relaxes. If your diaphragm is weak, then you actually are depending on your chest. So you'll use your chest muscles to pull your chest up, but your diaphragm, because it can't pull down and exhale the same way, actually gets pulled up into the chest. And so the chest will get bigger while the belly sort of sucks in, and it's an inefficient type of breathing. On the flip side, if someone has normal diaphragm strength, but they have weak muscles of the chest wall, then what can happen is instead of everything sort of expanding at once, the diaphragm pulls down and then the chest muscles sort of allow the chest to implode. So you see a similar pattern to what we see with diaphragm weakness, where instead of the chest and the belly moving together, they sort of seesaw. You get this alternating pattern where one goes in while the other goes out, and then they switch. And it's just an inefficient method of breathing, and it takes more work to get the same amount of air in and out. Another way muscle differences can impact breathing is even if your actual muscles of breathing have normal strength, if you have weakness of the muscles surrounding your spine and supporting your chest and your lower back, you can develop scoliosis. So even if you have normal diaphragm strength, normal chest muscle strength, the intercostals, if the spine is curved or twisted, then it really just sort of changes the alignment of the muscles inside the chest and makes them inefficient. So it can make it harder for someone with significant scoliosis to breathe, even with normal muscle strength. And then just because of the changes in the shape of the ribs and changes of the chest shape, parts of the lungs can be held almost in sort of like a squished closed position, and parts of the lung can be held open, and just again makes it harder for the lungs to get air in and out every minute. And then when we're sick, we think about muscle illness, muscle differences, and coughing, trying to clear out your secretions. There are multiple places where muscle differences can impact the ability to cough. So if you can't take a deep breath in, you're not going to get that effective cough. If you can't, if there's weakness of the abdominal muscles, you can't exhale forcefully, so it's going to have an ineffective cough. Separately, this is not something that really happens or is not described very much with the different muscular dystrophies, but if someone also, if their vocal cords don't work, if they can't control and hold their cords closed and time them to open when they want, it's also hard to get a cough because you can't build up that pressure behind it. So anytime you are unable to cough effectively and get the mucus and things up, it can cause you to have lower oxygen levels. It's harder to get that good air in, and it increases the risk of pneumonias because bacteria like to sneak in there back behind that mucus that's stuck in the airways. It makes a nice little warm, moist home for them to create a pneumonia. So one of the major reasons why effective cough is so important for breathing. And so just sort of taking a step back and looking at muscular dystrophies or any cause really of muscle weakness, there are the different ways that it can affect breathing. That if there's a weakness of the muscles of the trunk can contribute to scoliosis, which makes breathing less effective. Weakness of the breathing muscles can make it difficult to get air in or difficult to get secretions out. And then if there's weakness of the muscles of the throat, can cause risk of aspiration, which of course is not good for your lungs. Aspiration being where you inhale either saliva or secretions or something that you're eating or drinking into your lungs. Your lungs don't like that, causes inflammation, and then is more stuff to need to cough out. And then also folks with bulbar muscle weakness are more prone to airway obstruction, things like obstructive sleep apnea. So multiple different ways that different muscle groups can combine to contribute to difficulty breathing. And then looking at the limb-girdle muscle dystrophy in particular, and sort of what we expect, because this is really such, there's such a variety of different presentations and different ways LGMD can present. With the autosomal dominant muscular dystrophies, the LGMD1, we really don't, there's not a lot described in the literature in terms of respiratory muscle weakness. Again, as everyone else has said, within LGMD, there is a spectrum of presentation, even folks with the same type or even this exact same genetic mutation. So there are certainly individuals with autosomal dominant limb-girdle who do have respiratory muscle strength, but it's not something that we are typically expecting. What we do see more commonly with the autosomal dominant type is in some types, folks are much more likely to have scoliosis, which can impact breathing, or trouble with swallow, which also can impact breathing. So that's sort of with the autosomal dominant groups, what we look for. And then with the recessive, autosomal recessive or LGMD2, there are different things we expect with some of the different types. But again, within any type, there is an array of presentation and severity. So just in particular, what we have seen in the literature and the cases that have been reported are that folks who have 2A or with the new nomenclature R1, there can be respiratory muscle weakness involved, but it tends to start later on in life in adulthood. And then the sarcoglycanopathies, the 2C, D, E, and F, or the R3, 4, 5, 6, the new nomenclature, and as well as 2I, those types are much more likely to have a respiratory muscle weakness, and folks are much more likely to benefit from different technology to help with breathing and secretion clearance. The current guidelines from the American Academy of Neurology recognize that 2B and 2L in particular have very rare respiratory muscle involvement. And so those are actually the two types that are sort of excluded from regular respiratory screening and testing unless somebody is symptomatic. So I'll talk more in a moment about lung function testing, pulmonary function testing, and sleep studies, which we tend to do for folks who have respiratory muscle differences on a regular basis, even if they don't have symptoms, because we know we can pick up on changes before symptoms occur. But folks with the autosomal recessive 2B and 2L are sort of called out specifically by the American Academy of Neurology as not needing that regular screening unless they have some symptoms of challenges with breathing or sleep. And now I'll get into a bit about how we monitor lung health. And I'm sure many of you have done much of this over time. Pulmonary function tests are something that you can do at your MDA care center, your pulmonologist. And really we look for a couple of main things. One is we do spirometry, which you can see here through the cartoon of an adult breathing into this device, or this cute little guy over on the right, doing his PFTs, where essentially we measure air going in and out when you're just breathing comfortably, and then we ask for you to take as large a breath as possible and blow it out as far as you can. And we also look at coughing. And what we're doing is we're measuring how big are the breaths, how fast is the air moving, and through that sort of estimate if we're seeing any differences in terms of how big a breath can you take, how effective are you at getting it out. And typically it's recommended, depending on the type of muscle dystrophy and what symptoms you have, that lung function testing be at least once a year. Often in kids, especially where things are changing, we'll do at least twice a year. And some of the things that we look at, we trend over time. Everyone's lung function changes over time. So here's a graph of just sort of, honestly, it's sort of an arbitrary value, but what we see is that for most folks breathing, as you grow, your breath sizes get bigger, and then they sort of slowly get smaller over time. And that's to be expected. And so the absolute value, the absolute measure of your lung function testing isn't actually as important as the trend over time, which is one reason why we keep tab of things. So if you look at this middle red line here, let's say if we measure someone's lung function testing through whatever this test is, and they're measuring at a 3, if we're looking at this person here who's been along this red line, we say, that's great, you're stable, everything is as it was. But if we do a test and we get a 3, and it's somebody who maybe was this top red line or one of these black lines, that's a huge change and really tells us we need to look into why are things different for this person. So the same value for different people can mean very different things. So this is an example, just a picture of some of the things that we look at in the pulmonary function testing, where each of these little gray squiggles is just a quiet breath, a regular breath, where you see the swoop up, that's breathing in, and then the hill comes back down, that's breathing out. And then you see where we ask someone to take as huge a breath as they could and then blow it out as far as they can. And when we compare, let's say, an individual of the same sex and the same height, with regular muscle strength and then differences in their muscle strength for one reason or another, what we see is that someone who has decreased muscle strength is going to have slightly smaller breaths even when they're breathing comfortably. And so to make up for that, to get the same amount of air in and air out every minute, because the breaths are smaller, you can breathe a little bit faster. And what's more notable is that when someone tries to take their hugest breath in and blow it all the way out, the size of that large breath is going to be smaller. So when you see your pulmonologist and they talk to you about some of your different measures, we have so many acronyms and it all runs together, but the forced vital capacity, or the FVC, that's that huge breath. How big a breath can you take? And that tells us a lot about your muscles of inhalation, your inspiratory muscle strength. And then the FEV1 is another thing they might tell you about, which is how much breath can you blow out in that first second, which tells us about your expiratory muscles. In someone who has asthma or lower airways disease, it can also tell us about lower airways. But if we assume healthy lungs and healthy airways, then that FEV1 can tell us about how strong are your muscles, how effectively can you push that air out in the first second. So those are two of the major things that we look for in spirometry. And then another thing that we have, excuse me if I say kids, I'm a pediatrician, so I talk about kids most of the time. When we have folks do their pulmonary function testing, we see how large a pressure can you create on an inhale, essentially sucking against a closed valve, and how large a pressure can you create blowing out against a closed valve. So that's the MIP and the MEP, the maximal inspiratory and expiratory pressure. And again, those tell us some about inspiratory and expiratory muscle strength. And then the cough peak flow, which is what we measure, how great a flow can you create on a cough, which tells us again about expiratory muscle strength. So keeping track of these lung function testing, the pulmonary function testing, really helps us anticipate when breathing strength is changing over time. and lets us know when is it going to be worthwhile to help this person have more devices or medications or what have you at home to help them breathe when they're sick. Because we're going to see changes in the lung function testing before, for the most part, before anyone feels changes when they're healthy and breathing and living their best lives. So if we've got a low forced vital capacity, so a low huge breath, or a low maximal inspiratory pressure, then we know this person is starting to have weakness of their muscles to breathe in. And so we start to say, you know what? This person is going to start to have trouble ventilating, getting that carbon dioxide out. And we know that the place we're most likely to see that first is in sleep. So maybe we need to start talking about some testing in sleep, which I'll talk about next. If we have a low expiratory pressure or a low cough peak flow, that's when we say, you know what, I wonder if this person is able to cough effectively, and maybe we need to get them set up with some equipment to have when they're sick to make sure they can get their secretions up and out. And now, like I said, another way that we regularly test things to keep tabs on breathing is with sleep studies. So pulmonary function testing is something where you're putting in effort. A sleep study is nice and relaxing. You get to come in and basically have somebody monitor you. There's no effort involved except for sleeping and then going to the lab and generally not having the best night's sleep. So a full sleep study, which is the kind we typically provide for children, is where you go spend the night in an accredited sleep center and you get hooked up with all of these sensors. We've got the brain electrodes, heart, belts to check on breathing, all of these things. And it really provides a ton of information. It tells us about how are you sleeping, what stage of sleep are you on, how often do you have these little sort of micro awakenings that you may not remember later on, but really do interfere with the restfulness of your sleep. Tells us how much you move in sleep, what position are you in, how well are you keeping oxygen levels up and getting that carbon dioxide out. And then also information on heart rate and then sometimes blood pressure depending on where you are. So a lot of information. This picture here is just a schematic. On a typical sleep study, we'll have about 400 of these screens. Did I do that right? 200? Yep, about 400 of those screens of data to go through. So a lot of information to come out of it that tells us a lot about how you're sleeping. It does mean going to a lab, spending a night in a different bed, having a ton of stuff stuck on you, and then knowing that you're being monitored overnight, which some people are not comfortable with. So while this provides the most information, it's not necessary for everybody. And there are alternative options, which I'll talk about in a moment. But it does, in terms of breathing, gives us a lot of information. Some of the terms you might hear about if you've had a sleep study or you've heard someone talk about their sleep study is the AHI, which is the apnea-hypopnea index, which really is just the number of times per minute, per hour, that you're breathing. A change in your breathing either causes your oxygen levels to drop or causes your body to have to wake up and respond to it. So an apnea is when you really have a complete pause in breathing, and a hypopnea is when the breathing is shallow and you have a response to it. So an AHI or apnea-hypopnea index, we say in children should typically be less than 1 for events where your body is trying to breathe, but for some reason is getting blocked up. In adults, we give adults a little more leeway. In adults, an AHI of 5 or less is considered normal. And then separately, looking at how you get your CO2 out, we see some folks, even if their oxygen levels are perfect, they're breathing a little shallowly, they're not breathing as effectively, their CO2 starts to creep up in the night, especially REM sleep. And so when your inspiratory muscles are showing weakness, really your REM sleep is the first place that information is going to show up. And then later on, your non-REM sleep, breathing when you're sick, and then breathing when you are well and awake is the last place we see differences typically. For folks who staying overnight in a sleep lab is not an option or not a desired option, there are some different technology opportunities for home. Just an overnight pulse oximetry study where we just keep track of your oxygen levels is an option for everybody. It really provides information on oxygen only, doesn't tell us about sleep quality, doesn't tell us about snoring, doesn't tell us about ventilation, but it can certainly be used as just a signal for, oh, things are going very atypically. This person has a lot of low oxygen level. We really need them to come in. Or if the overnight oxygen levels look perfect, we can say, you know, maybe if we got the full sleep study, things would not be perfect, but we feel like that we're at least in a safe place. Home sleep studies are sort of an in-between, where they give a lot more information than just the pulse ox, less information than a sleep study in a sleep center, and they're largely limited to adults or larger adolescents. We don't really have good home study options for kids. But it can give you a lot of the information from a sleep study, except for the carbon dioxide levels, the ventilation. We don't get that information from a home sleep study at this point. It's also not as sensitive for little awakenings or disruptions to sleep quality, although some of the new systems try to estimate that. So these two studies can really be used to say, this person looks really pretty darn good. This person looks like they're really struggling, having lots of low oxygen levels. But it's really that sort of the gray area in between when things are changing a little bit that these home studies are not going to pick up as well. And so once we've identified that someone's breathing is different or harder to do or not breathing effectively, we do have lots of different things, areas where we can intervene and provide help. The very first thing to do, I will say, is prevention is the best medicine. Getting your vaccinations, especially those that are related to respiratory illness, is important. We recommend for everyone the flu shot every fall. Folks with all muscular dystrophies qualify for the extended pneumonia vaccine, the Pneumovax. Now that the COVID-19 vaccine is available, we certainly recommend that for all of our patients who qualify. And then for the really young kids, there is kids who are have their breathing muscles affected when they're young. There is it's not a vaccine, but it is an intramuscular treatment to prevent RSV infection, which is one of the gnarly viruses that makes kids really sick. But once we're past the vaccines, as a pulmonologist and a pediatrician, those are my favorite. But once we're past that, we look at how can we help folks breathe and clear their secretions more effectively. So there are many different options. One of the first things that people learn, some people do this intuitively without even thinking, without being told to do it, is they breath stack. So when your inspiratory muscles start to get weak and you can feel that you're not getting big breaths, some people will just intuitively breath stack, where instead of inhaling and exhaling, they'll inhale, close their vocal cords, and then inhale again and do it again, maybe 3 or 4 times. So they get 3 or 4 times the normal breath into their chest to really help stretch things open and get essentially like a big sigh breath. So some people can do that on their own. Some folks like to do that with some assistance. So this top right picture here, you see a woman who's got a self-inflating bag that can be used to help assist getting a big breath in. There are other devices with a mouthpiece where you can get a big breath of volume in. Sometimes people will use their BiPAP machine for this. A cough assist can be used for this, or a ventilator. There are lots of options for ways to help get a big breath in, which can just feel really good to get that good big chest stretch sometimes if your muscles aren't able to do that independently. And then sort of the next thing that we think about is getting the secretions out. So there are a couple different options. So manually assisted cough is some folks, I know some individuals who do this on their own, where essentially it's you get a big breath in, either because you can breath stack on your own or you use one of these techniques I talked about up here. And then if you have a partner to help you, someone puts their hands on your belly just at or just below your diaphragm and helps push out, timing with your cough to help get that more forceful exhale. I know some individuals who they'll put a pillow or something on their lap and sort of do it themselves, lean forward onto the pillow to help push the air out. Both of these together are more effective than either one alone. But people often sort of create their own little menu, mix and match the ways to help get the big breath in and the secretions out. Another sort of really commonly prescribed thing we use is cough assist. It didn't need its own slide, it just didn't fit on the last one. You'll hear it called different things. It's mechanical insufflation, exsufflation, or MIE, or cough assist, which is essentially, it's a device with a hose, and it connects to you either from a mask or a mouthpiece, or if someone has a tracheostomy. And what it does is it sort of gives pressure in to help get that big breath, and then it does a negative pressure, so it essentially helps suck the air out, and the idea is that it brings the secretions up and with it. So there are pros and cons between using the mechanical, the MIE, versus the manually assisted cough, and really both can be effective, and the best option is whatever works for the person who needs help coughing. Other things we do to get secretions out that really, some help some folks, some aren't necessary, we can help to essentially shake secretions loose. This is more important for folks who make more secretions, either in the case of muscular dystrophy, often more when they're ill. We have the vest, the shaky vest people talk about. There are different mouthpieces, you can blow on to help essentially create a little bit of percussion in your airways to help shake secretions loose, and makes them easier to cough out. Suction machines can be very helpful, especially for folks who can get the cough secretions up into the back of their throat and then have trouble getting them the rest of the way out. Or there are different medical managements, inhalers, or treatments to decrease secretions depending on where they're coming from. And then sometimes, even after we've got our big breaths in and we've cleared our secretions, there can still be troubles with keeping oxygen levels up and carbon dioxide levels low. And so then we look at what can we do to help with breathing, to help with ventilation. And there's really sort of a spectrum from doing the most assistance to the least, or vice versa, least to most. So supplemental oxygen can be useful for some diagnoses. In muscular dystrophy, we tend to not recommend them because they don't actually treat what the problem is, but they do often cover up our signal. So they will raise oxygen levels, but don't actually help clear secretions or help keep the lungs open or help get CO2 out. So with a few exceptions, we generally don't recommend the use of oxygen alone for any of our patients with muscular dystrophy. Sort of the next step is called CPAP, continuous positive airway pressure, which is usually provided by a mask. And it's really just one pressure, and it's used to help hold things open. So it doesn't take away the work of breathing, doesn't give you bigger breaths, but it can help hold things open. So most classically, it helps hold open the upper airway, especially if somebody has obstructive sleep apnea. CPAP is the sort of mainstay therapy for that. Or if somebody just has sort of small chest, we can use CPAP to help hold things open, and then they breathe on top of it. BiPAP is much more commonly used with muscle weakness or different muscular dystrophies, which is it's bi-level positive airway pressure. So you get the CPAP is in there, it's help holding things open, but then the device senses when you're trying to breathe, and so it adds extra pressure, extra flow to help make the breaths bigger and take away some of the work of breathing. CPAP and BiPAP are not portable. They, as a rule, don't have external batteries, so this is really something that's kept at a bed or at a chair and doesn't go around with you, as opposed to a ventilator, which is portable. They have external batteries. Ventilators, people think of most commonly as going along with a tracheostomy, but they can be used with the mask or a mouthpiece as well. So it's not limited to folks with a tracheostomy, although insurance approval can be trickier if you don't have a tracheostomy. But ventilators can be set in all kinds of different modes. The ventilator can be set for CPAP or BiPAP, or something that's really more like a true ventilator, giving specific breath size at a specific rate. Or one of the sort of the more common ways that we use ventilators for our kids who are on the go and don't want to be hooked up to something all the time is called mouthpiece ventilation, which I'll show you a picture of in a moment. So here are just some images of different interfaces for CPAP or BiPAP or ventilators. So our top row, we've got our kids. The draft mask is everyone's favorite. So just different masks that provide flow of air, mostly into the nose for kids. For adults, there's also an array of options of masks. For adults, we can provide airflow either just into the nose or into the nose and the mouth. Lots of different styles available these days. There's new ones every year. We find I really like this gentleman in the center on the bottom row, these new mask designs where there's no hose coming out the front of your face. It connects through the headgear and comes out the top. And so it's a lot more comfortable and sort of less invasive and annoying for people to use, especially if they benefit or they like having some support on and off during the day. Over on the left is just a couple of options of the sort of the bedside or chair side devices that we use for CPAP or BiPAP. And then this little guy with the blue doggy, I think. This is something I hadn't touched on. Negative pressure ventilation is another thing that we use sometimes with muscle weakness. It's called the cuirass, or we call it a turtle shell sometimes. It's a hard plastic device that has a soft seal that goes around the chest, and it essentially uses, instead of blowing air in, it sort of pulls air out of that space and pulls the chest open, and so helps sort of augment that movement of the chest to get bigger breaths that this little guy is trying to take on his own. Once we go past that, we talk about the ventilators. Here, attached to this chair on the left is what I was talking about, the mouthpiece ventilation, or sip and puff is what our teenagers call it more commonly. Where you have a ventilator, it's typically attached to a chair, and then it has a mouthpiece that can be set either to the side. These two guys on the top row here are showing two different models. Where it's set up so that it's sitting there, it's available, it's not doing anything on its own until one of these young men puts his mouth on it, essentially tells it that he wants a breath. And then the ventilator gives a breath that we have programmed, based on what he says is comfortable. And so every once in a while, he can just get a really big breath, get that big stretch, that feeling of his lungs being nice and open, and use that as often as he likes. So I have young men who have this on their chair and they use it once or twice an hour. And then some folks who maybe they benefit from a ventilator all the time, but they don't want tracheostomy, or they're just, for whatever reason, cannot have one. And so they will use this all the time, but then they can let go of it and they can talk and they can do all these things and feel sort of more mobile, and gives them a lot more freedom, a lot more breath to talk with, and sort of more mobility and independence this way. And then this bottom row here is just sort of the three main ventilators that we're seeing in use these days. The LTV, at least here in the Pacific Northwest, we don't have very many of them out anymore, so that picture's not on there. But the Trilogy, the Astral, and the Voxen are sort of the three main players, different ventilators that we're using. They're all portable. They all have good battery life. There are pros and cons to them. But honestly, a lot of the decision in terms of which ventilator somebody who needs a ventilator gets has to do with what home care companies are near them and what they supply. But they're all good at what they do. So switching gears now a little bit off of ventilation, thinking about sick care with muscular dystrophy or LGMD, is we recommend our patients when they're sick to keep tabs of their oxygen saturations. This 95% limit we use for most of our kids. Healthy kids should be sitting up at 99, 100% most of the time. In adult care centers, caring for older adults, their lower limit may be less, because as we age, our saturations will drop a little bit lower. But for our kids, what we say is, if your saturations are less than 95%, it's time to kick things up a little bit and do more. So do more of your secretion clearance, whether it's cough assist or manually assisted cough, whatever it is that you do. If you're doing those extra treatments and your saturations are still low, then you need to be seen either by your pulmonologist or some other local provider. If we see an individual in the ER with muscle differences who has saturations less than 95%, even after we've helped them clear secretions, we'll often, get an X-ray to look for any changes in the lungs, check a blood gas to make sure that their carbon dioxide levels are not getting very high, and have a very low threshold to give antibiotics because we know that risk of pneumonia is higher. And we always recommend, I always talk to all of my families about, if you're in an ER or a hospital where they don't take care of a lot of folks with neuromuscular weakness, muscular dystrophy, you really need to advocate for yourself and not let people just put you on oxygen. Because your oxygen levels are low, we say if you have muscular dystrophy and your oxygen levels are low, that treatment with positive pressure is the most important thing, whether it's CPAP or BiPAP or whatever method they have at that institution. That is the treatment for low oxygen levels with muscle weakness, because the problem is not that you need more oxygen, it's that you need more of your lung popped open and bringing that good air in and sending that bad air out. And then sort of just the final topic to touch on is breathing with muscular dystrophies when you're going to have sedation or procedures. One is just make sure that your diagnosis is on the radar of your surgeon and your anesthesiologist so that they're thinking about it. Again, especially important if you're at a center where they do not specialize in neuromuscular diagnoses. By and large, with muscular dystrophies, we say avoid succinylcholine and inhaled anesthetics because there's increased risk of muscle breakdown, rhabdomyolysis, or high potassium levels and electrolyte abnormalities. If you're having a major procedure that requires sedation, most places will request that you've seen your cardiologist and your pulmonologist within 6 months, just to help them, not so much with the procedure, but to know how to help care for you afterward, what kind of support you might need in recovery in the post-operative area. Along with that, if you are someone who uses cough assist or other assistance at baseline, you should plan ahead to make sure you have that available or that the hospital has that available in the recovery area after surgery. And just expect that if you are someone who needs positive pressure support, either at baseline or if you know you've needed it in the past after sedation, we often expect that there will be an ICU stay, even if it's just for observation and everything goes well, just to make sure that you have good eyes on you to make sure that lungs are staying nice and open. So in summary, muscle disease, muscular dystrophies can impact breathing in various ways through breathing in, ability to breathe out, ability to clear secretions, and protect the airway. And it does not always perfectly correlate with exactly what your diagnosis is, but that is a good starting point for us sometimes to know what to expect and how often to keep tabs on things. For most of the autosomal recessive or the type 2 limb-girdle muscular dystrophies, you should be seeing a pulmonologist at least once a year and getting some lung function testing. I find it is always best to have equipment early. Even if you feel perfect, you've never been sick, you've never had pneumonia, but we're seeing changes in the lung function testing, it's best to have equipment on hand so that you have it there the first time you get sick, once your muscles have started to change, instead of waiting, saying, I don't need it yet, and then you're more likely to end up in the hospital with a more significant infection. Be, as always, an advocate for yourself, especially when you're in places where providers are not experts in neuromuscular weakness, and protect yourself with all of the vaccines available to you. And that is all that I have planned.
Thank you, Dr. MacKintosh.
Yeah.
I have a couple questions. I was curious, do you recommend anything for skin breakdown when you are wearing a mask for your CPAP machine?
It really depends on the person. I have,
Okay.
I have slides on another PowerPoint where I actually talk all about that, all about accessories to mask usage. So there, I would say, as with most things, the answer is it depends. Some people can, like I wear my CPAP mask every night and I don't have skin issues. So
Okay.
if you can wear it and you have no issues, great. Don't bother with extra things. If you can wear them and you do have issues, there are lots of sort of commercially available things these days, different mask liners. There's some on Amazon. There are a couple of like Etsy shops that specialize in fitted mask covers for whatever specific mask that you have. A couple of the mask companies are now starting to make some that have like a memory foam. So where the part where the mask touches your face is memory foam instead of silicone.
Okay.
So essentially just sort of check out what you have. You know, we're limited by insurance how often you can replace your mask, but
Hmm.
whenever you are available or you're eligible for the full mask, headgear, all of that, I recommend if you have any issues with your mask, meet with your home care company and say, you know, can I have a mask fitting? And they'll bring you like the suitcase of all of the
Okay.
30 masks they have these days. So really honestly, the best option is whatever works for you and lets you wear it. And it's completely different for everybody.
We had a person mention that they used all of those masks that you had put up there.
Oh yeah.
A lot of people kind of go through all of them. What
Yeah.
does this person has typed into the chat? They said, "What could finger clubbing mean if lung function tests are normal?"
So clubbing can be, you know, we think of it classically with a couple of different things. So, and it depends on, you know, the age at which it happens. So first I'll say that there is familial clubbing. So
Okay.
some families just have a clubbed shape to their fingers and there's nothing. That is just the family shape. So if everybody in your family has clubbed fingers and nobody has any chronic illnesses, then it may just be the shape of your fingers.
Okay.
We'd never go to that first, right? We always sort of think about clubbing. So low oxygen levels, or particularly cardiac disease
Okay.
is one thing that tends to present in childhood. It's if there's a congenital heart disease, different airway diseases. So purulent lung diseases we talk about, if there's bronchiectasis or airway disease, those can cause clubbing, things like cystic fibrosis or bronchiectasis. Those are things purulent airway diseases can present with normal lung function.
Hmm.
And so if you've had normal lung function testing but not seen a pulmonologist, it may make sense to meet with somebody and think about a CT scan to look about how the chest actually looks. And then we also, and I will fully admit I'm less an expert in this, liver disease can also contribute to clubbing. And so evaluation by a GI doc is one thing that we do if I don't find an answer that makes sense to me.
Okay. We have a person type in they had scoliosis as a youth, sorry, and used a back brace until they were done growing. They have limb girdle 2D. Would wearing a back brace again help the breathing since they still have scoliosis?
Yeah, honestly, probably not. Back braces in the moment when they're on, if anything, most commonly make it more difficult to take big breaths in because they've got to
Interesting.
be strapped around you.
Okay.
The flip side is the benefit, right, is if the bracing can prevent the scoliosis from getting worse, right, then there's a net benefit. And so we tolerate that temporary restriction from the bracing because we're looking for a long-term gain. For adults, it's very unlikely that a back brace would help unless you find that a back brace puts you in a position where breathing is easier.
Okay.
Usually for adults with scoliosis, things are sort of fixed and set where they are. And so I would not typically expect a brace to be helpful for breathing.
Okay. This person says they've been told they don't exhale well. Can you explain what muscles affect when you exhale a breath?
Yeah, so there's the main muscles involved in exhaling. So when we're just exhaling at rest, we don't really use our muscles. If there is slow exhale or inefficient exhale at rest, then that is more likely related to smaller airways. So if you've ever seen somebody with asthma who's having an asthma flare exhale, they have to like they exhale for a long time and you can hear it and it's a lot of work. So lower airways can be
Okay.
one non-muscle related reason for difficulty exhaling. When you're doing a forceful exhale, the most important muscles are the abdominal muscles. So sort of those front abdominals and the obliques. Some some part of it is we use some of the intercostals, so the muscles in between our ribs. Some of those we use for exhaling, but the belly muscles are the most important.
Okay. Is there any value in singing to help with the vocal cords? This person's noticed some changes with their breathing.
I think there's, it very well may be. It depends.
Okay.
There are some diagnoses where the vocal cords, the nerves controlling the vocal cords don't work. And so in that case, no, that would be a reason to see an otolaryngologist and make sure that your vocal cords can open and close,
Okay.
especially in adults. But that being said, there is a lot of conscious and unconscious thought that goes into the control of the vocal cords. And so we know that there's a diagnosis that has many names now, and they all sound scary, but none of them are. It's vocal cord dysfunction or paradoxical vocal fold motion, or now they're calling it, I think, exercise-induced laryngo something. But essentially, it's where, right, you can imagine when you're talking, your vocal cords move in and out, and that's how you control your voice. When you take a big breath in, you want them to be really wide open to make room for that air to go in. When you're going to cough, you want them to close. So you want them to do what you want them to do. We know that sometimes we can get into these cycles, and it's more common in people who tend to have underlying anxiety, where essentially you sort of get into this this circular pathway where your vocal cords don't do exactly what you want them to do. It's not dangerous, vocal cord dysfunction. They do what needs to be done. They just don't always do what's convenient. And so it can make it feel like it's harder to breathe. Some people say they feel like they can't get a full breath in. When they're taking a big breath, they can say, either I have a pain right here, or I feel like it's getting caught right here. And those issues in particular can very much be helped by speech therapy, where they'll work on things like throat exercises or like singing. A lot of singing exercises are actually throat exercises. So in that case, yes, singing and throat exercises can be very helpful, but especially for adults, if you feel like you're having vocal cord issues, it's really important to be seen and evaluated before we just write it off as a vocal cord function issue.
Okay, that's a good point. This person says they've been diagnosed with restrictive lung disease due to their limb girdle. Is an incentive spirometer a good idea, or do you have any other ideas?
Incentive spirometer is really never a bad idea. Restrictive lung disease is really where it's the main thing is with trouble inhaling. And that can be, folks can have restrictive lung disease for a couple different reasons. One is their muscles, right, are either not strong enough to take the big breath, or there's something about the chest where the chest isn't flexible enough to take a big breath. And so an incentive spirometer, one thing is it's just essentially an exercise in taking the big breaths. So it is good for sort of muscle usage and exercise, and also just every once in a while getting your lungs nice and open. But some of the technology that I talked about, like the breath stacking, or ventilator BiPAP at night, can be more helpful in terms of getting big breath in without tiring out your muscles. But it depends on how restrictive and exactly why things are that way.
Okay. And I want to be cognizant of our time. I know we're a little bit over, but I just want to get to these last few questions.
Yeah. Great.
Is there a difference between finding a pulmonologist that deals with muscle issues and not just lung issues? This person says that their experience with most pulmonologists is they just want to give him an inhaler, but not necessarily really looking in his muscle issue of his respiratory function. Do you have any comment to that?
Yeah, I think all pulmonologists have had training in neuromuscular issues.
Oh, okay.
But right, once you leave training, if you don't see something very commonly, you sort of get out of practice and stop thinking about those things. And so unfortunately, I think the physicians who are really practiced in seeing neuromuscular issues tend to be at larger centers, academic centers. And so I know that similar to when Ms. Bivona put up the, how to find the genetic counselor, the MDA has a list of sites on their website where you can find pulmonologists or muscular dystrophy care centers in your area. And so I think looking for a larger care center is your best bet.
Okay.
And again, one last thing is also, like I said, unfortunately, we hope that we never have to advocate for ourselves, but sometimes if you just go in and say, I have muscular dystrophy, I suspect you don't see it often, here is what I think I might need. Sometimes they'll have those resources available. It's just not the first thing they think of.
That's a really good point. This person, and I just want to finish up real briefly here, they suffer from excessive sweating, and the sleep study technician told them that that might be due to not being able to release all of the carbon dioxide. Is there any truth to that?
So we do see sometimes when someone is having difficulty breathing in sleep, they do get very sweaty, but it's not directly related to the carbon dioxide. And on a sleep study, they should be able to measure your carbon dioxide. Especially in adult centers, they don't always do that. In pediatric centers, we do, and in when we're looking at an individual with neuromuscular weakness, we're worried about ventilation. They should be checking that.
Okay, perfect. Well, thank you so much, Dr. MacKintosh, for being with us today. We got through all of our questions. Thankfully, we did run a little bit over, so I apologize if we got into your Saturday.
Well, thank you for having me.
Thank you.